So the first case we have, I'm going to call on Silva since I see that you're on.
Yep.
This is a 52-year-old female who presents with hypertension and 1 year of progressive left calf pain that radiated to the bottom of just the left foot only. Eventually, though, it did start to radiate to the other side of the foot after about 9 months, and just in the calf and lower foot. And then eventually she developed pain down the buttock and the lateral aspect of the right calf, and then continuing down to the foot. And that's when we see her finally in clinic, and she is intact on exam, has normal reflexes. So this is your first image. Tell me what you see here.
Looks like a T2 hypointense lesion, ventral to the nerve roots, right about at the level of L3. Yeah, maybe some stenos along the nerve roots. Yeah.
And then, do you think it's above the conus, below the conus?
It looks below it. On the axial, I think I see separate nerve roots, but it's a little hard to tell.
I agree. It looks like it may be a little low even, but yeah, totally agree. Okay, so here's a, I'll give it away. It's T1 with and without. And what do you see?
Yeah, it looks like a heterogeneously enhancing lesion, T1 isointense. It's a little eccentric to the, it's the left there.
Yeah. Perfect. Okay. So do you have a differential in mind?
Yeah, so it looks like a intradural mass kind of at the lumbar area. So on the differential would be something like a ependymoma, metastasis. Less likely would be like a meningioma or something like that.
Perfect. Yeah, and then a couple others could be schwannoma, intracanalicular, neurofibroma. But yeah, you got them. So I will turn it over to Dr. Saad for this part. Stop sharing.
Okay, good morning, everyone. So this is the tumor at low magnification. Whoever said myxopapillary ependymoma is correct, and why is that? Because at low magnification, you have these papillary structures that are in cross section. That's why you don't see the fibrovascular core, but rather you see the lumen. And around the papillae, you have this palisading of ependymal cells. And one can make the point here that there is vague ependymal pseudorosette. So pseudorosette, as we all know, there are tumor cells that are palisading around a blood vessel. Higher magnification. So if you're gonna get a question about this entity when you take your board, this would be it. So myxoid areas, tons of them, and then papillary structures. Most of them in this particular case are in cross section. Higher magnification, the tumor cells have very minimal atypia and pleomorphism, but high-grade features such as necrosis, vascular proliferation, and mitosis are absent. By immunostain, this is indeed a glioma because it is positive for GFAP. EMA has a characteristic pattern in ependymoma in that it shows intracytoplasmic dot-like positivity. The only CNS tumor that does that are tumors of ependymal differentiation. And as common in myxopapillary ependymoma, Ki67 is very low. It's about 1 to 2%.
Thank you, Dr. Saad. Let's go back to the PowerPoint. So I'll just go through those quickly. Yeah, to recap, it's a subtype of ependymoma that occurs along the conus, medullaris, the phylum Terminale, and the cauda equina. They are the technically most common glioma of the lower cord, conus, phylum, and they're a myxopapillary subtype. So that's the type that ependymomas are most common for the lower cord of all types of ependymomas. But then once you get down to the conus, phylum, and the cauda equina, then you're going to see the myxopapillary subtype, which is has a slight male predominance, peaks into the 3rd to 6th decade of life. So she meets one of those typical things. And then another typical thing is that there's usually symptoms present for a year in at least 80% of cases, which is suggestive of its slow growing nature, of course. So the myxopapillary subtype is a WHO grade 1. It's slow growing and benign, as I said, and it's usually solitary, meaning that there are not other lesions throughout the CNS that can occur with ependymomas in other areas of the central nervous system. The histology, as he said, is usually characterized as papillary on the boards or microcystic vacuoles. There should not be any anaplasia, which is an important feature here. And there are some rare things that are talked about in the literature that you should at least know about to know that there's a possibility so you can take the best care of your patients in the future. It's that even a myxopapillary type can seed intracranially following removal of a spinal tumor, and it has been reported. There's also very rare reports of systemic metastasis of the myxopapillary subtype. And it can occur, the myxopapillary type, outside the CNS in the sacrococcygeal subcutaneous tissues if the patient has rests of ependymal cells. Again, another rare occurrence, but definitely possibility embryologically. So good job, Silva. Thank you for your help with that. Let's see who's on Zoom. We have, this is a little higher level. Well, here we go, Adam. Sorry, you're up. I'll try to lead you along.
Okay, sounds good.
It's 22-year-old healthy male. He's active military and he's deployed at the time when he develops constant progressive left shin and ankle pain over 1 month while deployed. So he doesn't actually, have access to a physician like we would if we were at home. So he assumes this is just like degenerative or from working too hard and walking around carrying heavy packs. Eventually his big toe goes numb and he's noticed that he's had a limp for a couple of days. So he goes to the Air Force doctor and they note that he has a foot drop on exam, and they tell him that that's obviously something neurologic, but they don't know what, and they don't have any way to get anything more than an X-ray or CT scan, which was not obtained, given that they thought an MRI would be needed. So he has to wait till he gets back home from deployment. So he comes to see us in clinic, and by this time, he has no pain. He just has foot numbness, and it's really just isolated to this diagram here that he drew, very specific locations of numbness, and he has a foot drop, meaning that his foot dorsiflexion is weak. On physical exam, well, let's start with the broad differential of a foot drop before I get more specific with his exam. Can you tell me big categories of what can cause a foot drop? Adam? I think you're muted. Okay,
Sorry. Hello?
no worries. Here you go. Go ahead,
Yeah.
take some guesses.
So we're starting at like peripherally to more central. So I would think if there's a nerve root compression at that level of like the
I'll go back to his picture if that helps. What nerve it runs there? I like your idea of starting peripherally and running centrally. So what nerve is that then, if you can see the pointer pointing to? I'll give you some hints. So it's got your perineal nerve. It's one of the most common compressive mononeuropathies, and it's the most common in the lower extremity. You can have a malignant or even benign tumors that can cause these issues. Trauma is something you will get consulted for, like actual fractures of the fibular head that result in nerve injury, or even direct injury, like I've seen with Dr. Levy with a circular saw on a young construction worker. So you can also have something that's really rare called the intraneural ganglionic cyst. And then you can have metabolic things, drug toxicity, Charcot-Marie Tooth syndrome. This is really just a review for your boards. Lumbosacral plexopathy. But since this is a neurosurgery neuropath conference, we all know this is going to be surgical. So I gave it away here already. The nerve root, if you go more centrally, that's most commonly associated with foot drop is going to be L5. And finally, just have a couple central causes that could be very rare and unlikely, but a paracentral lesion of the motor strip, a parasagittal meningioma, a very, very focal spinal cord injury with MS or something like that. So here's an MRI. I'm showing you what level do you see on the axial? The line matches.
L4, L5.
Great. And do you see any compression there, those nerve roots?
No.
Perfect. Good job. So here's his physical exam. He actually has a palpable mass overlying the lateral aspect of the left lower extremity, right at the fibular head below the knee. On his examination, he's got 3 out of 5 for the tibialis anterior, so for dorsiflexion. He's got 1 out of 5 for the extensor hallucis longus, 4+ for foot eversion, 5 out of 5 ankle inversion or foot inversion, plantar flexion, knee flexion, hip flexion. The extension are all normal. And the right lower extremity, of course, is normal. And he does on exam have complete loss of sensation at the web space between the first and second toe, and it extends to the first toe. His Achilles reflex and otherwise his patellar reflexes are normal, no Levinsky, no clonus, etc. So I want you to try to tell me what is the one exam finding that helps you distinguish L5 radicular symptom from a perineal nerve symptom if they're both having not just like the leg pain or the weakness that can match, but what's the one thing that's going to be different between the two?
I'm not really sure if are we thinking like if it's an no, I'm not really sure if the differential like is based on like an upper motor versus a lower motor kind of.
That's okay. No, let me try to bump it up. I see a few more people on now. You did great. How about Eva? Are you available?
Yeah. So it's should be just like eversion of the foot.
Perfect.
So
well,
it's
inversion. Exactly. Yeah, I know what you're thinking. So it's the L5 nerve root. It goes to the tibial nerve, which innervates the tibialis posterior, that muscle. and that is a primary ankle inverter. The common perineal nerve does not go to that tibial muscle, so you will not see ankle weakness with inversion when you have a common perineal nerve injury. So that's a really good one to remember for your boards and for examining patients, avoiding EMGs and unnecessary studies if you can figure it out from your anatomy. So that's just a quick review of the muscles that are innervated by the common perineal nerve. We're going to go even further. Eva, how would you distinguish a deep perineal nerve injury from a superficial nerve injury?
I guess deep peroneal, would it be like you get like numbness in the first 2 digits of your toes?
That's the one really good one that gives it away if that's present. Sometimes you kind of have a complex lesion like this guy where maybe both are affected, some more than the others. Is there any difference in the muscles that you can think of, the type of weakness that you would notice?
Deep peroneal is like maybe like the EHL.
Yeah. Mm-hmm. Oh, so good start. The superficial is going to be mostly just loss of eversion and a tiny bit of plantar flexion. You really shouldn't have a ton of dorsiflexion weakness if you just were somehow able to affect the superficial nerve, but you would have significant sensory loss over the calf. And if it was the deep, you would have loss of foot and toe extension, like you said, and that would be for your dorsiflexion. You might have a little bit of eversion loss, but you'd have minimal sensory loss, like you said. Great space of the web space of the great toe only would be affected. So quick review for the isolated superficial perineal nerve palsy. You're going to lose foot eversion and some plantar flexion, and that's because your peroneus longus and peroneus brevis muscles are innervated specifically by this nerve. You're not going to have a very significant amount of dorsiflexion weakness. So the eversion is what you'll notice more, and then they will usually have a lot more sensory symptoms than the other patient. As you can see on the picture there, the green part is the common perineal nerve innervation from the lateral cutaneous nerve of the calf. This goes down the outside of the foot, or the calf and the shin into the top of the foot, but doesn't go into the web space, which it leaves for the deep one. So remember, superficial is lots of sensory loss and loss of eversion. So then if you were to affect the deep nerve, you're going to lose foot and toe extension. As we said, that's because it supplies multiple muscles: tibialis anterior, extensor digitorum longus, extensor hallucis longus, peroneus tertius, which is actually a little bit of an everter and a dorsiflexor, and then extensor digitorum brevis and the first digital or dorsal interosseous muscles. So you're going to have minimal sensory loss, and that is one really helpful thing. But if you're just trying to get a motor exam and trying to figure out from that alone, there is a way to determine the difference. So this is his MRI. It's a little tricky. I'm trying to give you a clue with my arrow here. It's you kind of already know where we're going to look, but you can see that this is a, I'll tell you, a T2 MRI of the leg. So on the axial over here, what nerve do you think I'm pointing to right now? If you can see my pointer, we'll go back a slide. This one is your tibia and your fibula.
Like common peroneal.
Yeah, probably it's as it begins, and you can see it looks, this is abnormal looking. It's enlarged. Here's a normal looking nerve next to a normal looking vessel. And here's it. What would you say that nerve looks like, maybe, if you would give it a word?
What do you mean? Like, what does that
Like, does it
mean?
look like a mass or does it look more like a cyst, especially like with that cut? Very hard to say.
Yeah, it's kind of hard.
Yeah, there's like extra fluid in the perineural sheath. It kind of looks like it. It's definitely hard to tell. This is definitely a rare case. I learned a lot on this one, so I don't expect you guys to get it off the bat. But you're doing great. Let me go to the next slide. So Dr. Saad, I'll turn it over to you.
Okay, thank you. Okay, so this is the lesion at low magnification. The lesion is surrounded by this thick fibrous layer, and you can see a little bit of fat, and in the center there is this lesion. Higher magnification, the lesion appears to be pseudocyst. By pseudocyst, I mean it's a cystic lesion that is devoid of a particular lining. And the content of the cyst appears to be myxoid. And there are some cells, but for the most part, it is myxoid. So this is how a ganglion cyst looks like. We think this is a ganglion cyst that arose in the sheath of the peroneal nerve.
That's awesome. Thank you, Dr. Saad. Because that is what it is. So this is a rare finding in neurosurgery, and it's been a perplexing issue for neurosurgeons. I think the first case was reported like 200 years ago, because usually there's a palpable mass on the side of the fibular head, which is an area where there's usually not a lot of excess tissue or fat. So you can actually feel the nerve, and that's why that's a common spot of nerve compression, because it's very superficial as it runs around the fibular head. So there was a few theories. There was a thought that maybe the epineurium would degenerate it into a cyst. Maybe it was a tumor that was causing this, but that never really matched up with the pathology. They thought there was some sort of extraneural cyst, like a synaptic or from some other nearby nerve that was unrelated and not continuous, somehow invading. And this is from Dr. Spinner from the Mayo Clinic, who did a lot of significant work on this topic and wrote several papers on it. And this is their paper where they decide that the articular theory is the one that unifies everything and makes the most sense. So it is a benign ganglion cyst. And as you can see there, there's a joint associated. So these can occur in other areas, but the most common area is the perineal nerve coming from the synovium. So it is a true ganglion cyst, and that's why the pathology looks like it's a ganglion cyst coming from the synovium, but it's inside the nerve. So how does it get there? That's been the debate and the major issue, because it affected how people treated it surgically. And oftentimes they would recur, the cyst would not be treated from the origin. And so of course it would come back, they would have worsening deficits. And the sooner you can decompress the cyst, the sooner you can get this 22-year-old's foot drop to hopefully improve, or at least not get any worse. So for a long time, especially in the pre-MRI era, we did not know what was going on with these. Some people, in about 40% of cases, were able to see that there was a nerve next to the joints, the articular nerve, with these common perineal cysts, and it sort of gave it away to some people that maybe this was coming from the synovium. But like I said, there were several theories, and that paper that I just referenced was published in, I think, 2009, and there was a series of papers from the early 2000s up into 2015 describing this phenomenon. So it's kind of newly interested thanks to the MRI era. But you see this, there's a common perineal. It's branching into superficial and deep, and the branch to the tibialis anterior. And then there's an articular branch that you can see coming off there before the nerve splits. And that branch it does go to the joint, as the name implies, and synovium can leak down the epineurium and then sort of leak backward into the nerve sheath of the entire nerve. There's multiple phases of this. There's an ascending phase, a descending phase, and they think that the muscle attachment from the biceps femoris or maybe from the fibular head causes this to stop getting larger and pushes it downward into the nerves, as you can see here. So this patient actually had it affect both the deep and superficial nerves. The deep was probably more affected than the superficial, but that's why his exam showed a little bit of eversion weakness, but mostly dorsiflexion weakness. And he had some ankle numbness and calf numbness, but mostly was complaining of that web space where the deep nerve goes. So this is just a super quick video from the Mayo Clinic about how you treat these, because this is not a very common thing we see. And Dr. Cote did this case. So you cut the muscle, find the nerve, the articular branch is what you have to find. If you don't find this, you don't cut it, then this is going to recur. And that's what's troubled surgeons for a long time. This is them showing the dissection. You're having to isolate each nerve, then use an oscillating saw to open up that synovium. You'll cut into the cyst. It decompresses. Then you have to do a neurolysis and close the synovium. So shockingly, this patient actually had a neurologist outpatient drain the cyst 3 times with a needle. And all 3 times his symptoms fortunately got much better. The cyst got smaller, but like the history would imply, it recurred. And eventually we saw him in our office, and Dr. Cote treated it by neurolysis of the articular branch of the common perineal nerve. So that is case number 2. So let's see who's available. David, are you free? Let's see. How about Sumed or Turkey?
I'm here.
Hey, Sumed, good morning.
Good morning.
So this next case number 3, it's a 65-year-old gentleman who initially presented back in 2016 or 15 with 7 years of thoracic myelopathy. He had a lot of bowel and bladder issues, but I'll give it away. He had an epinymoma at T7, T8, which Dr. Levy resected with 90 to 95% gross total. The pathology at that time was actually myxopapillary-like, and it had a very low Ki-67 index, no mitotic activity. So like I was just speaking about, this is a epinymoma day. It was more like one of the more benign ones that are found in the conus and more distally. But it recurred very quickly over a period of about 9 months. So what do you see here?
Yeah, in these images, I see the cord expansile lesion, mid-thoracic. I imagine you can see the laminectomy defect.
Exactly, yep.
So right at the area of the prior surgical intervention.
Mm-hmm. Perfect. Okay. And then our next series of images, this is what kind of MRI? What do you see?
Yeah, it looks like a contrasted enhanced MRI showing a similarly contrast enhancing lesion in the cord.
Perfect. And there's a little bit, it's kind of subtle, but this around the nodule, it's looks kind of like there's enhancement of the cord maybe, or scar tissue. It's really hard to tell. we had several radiologists weigh in, but definitely there's that nodular enhancement that you can see. And to recur in such a short period of time for what we know is to be a slow growing and benign lesion is concerning over a period of 9 months. So this is a gimme, but obviously recurrence, as you said, in the same area of surgery. And then ependymomas can transform into more malignant versions of ependymomas, or maybe the diagnosis was wrong the first time, but not to say that that can't happen. The sampling error does occur. So you could also have just a malignant transformation of a primary CNS tumor. So I'll give this over to Dr. Saad.
So I'm going to show you the biopsy from the recurrence. The initial biopsy from 2016 did not arrive on time for this presentation. So this is the tumor from November this year. At low magnification, it's very hard to call it ependymoma without immunostains and without proper history, because it doesn't show the characteristic features of ependymoma, which are pseudo-rosettes and some fibrillary, at least foci of fibrillary background. So, and this is higher magnification. I'm showing you the higher magnification to convince you that there is no malignant transformation. There is no vascular proliferation. So this is a blood vessel, and you can see the endothelium is still thin and composed of a single layer. And there is minimal atypia and pleomorphism, but definitely there are no mitosis. There is a little bit of necrosis, which we think is due either to therapy. I don't know if this patient was treated with radiation, or could be because the tumor is running out of space and starts to infarct itself. Similar to the other ependymoma I showed you earlier, the tumor is positive for GFAP, and also EMA shows the characteristic intracytoplasmic dot-like positivity, and Ki-67 is about 2%. So this is a recurrent ependymoma. It's still WHO grade 2.
Yeah, hey, Catherine, great job. I was just going to say that the original surgery was in 2016. And so it was, he recurred over a period of 5 years. He had like a very stable enhancement in the surgical bed, like you said, maybe 5% of the original tumor. And then over a period of a year, this last year, it's when it blew up. If you look at the original pathology, I don't know if you have it, but I certainly, looking at the report, it was a little bit vague as to, it was an ependymoma, but they weren't, they were sort of saying that there may be some atypical features to that original biopsy or tumor resection back in 2016.
They had said that tansitic, myxopapillary, but then they also said some areas of necrosis, like you're saying. So it was a little vague, I guess.
And did they say myxopapillary? I don't think they said
they said the features, but they also said other types of features. So it's sort of a mixed tumor.
Because it would be very unusual to have a myxopapillary in that location. Usually they're ependymomas of more standard ependymomas. Dr. Saad, any comments about that?
Well, we had a previous case of a myxopapillary of the conus. I'm not sure if Dr. Saad noticed any difference when reviewing the two different pathologies that showed any sort of more change towards an ependymoma, a typical ependymoma.
Yeah, I can look at it after this conference, but the slides didn't arrive on time. So we store these slides from 2016 offsite, and it takes 2 to 3 days to get them. So, but we'll compare 2016 to 2021, and we'll let you know if there is any important information.
For sure. Thank you.
Thanks.
Okay. So we have Victor Liu with us. Actually, Victor, get a break. Let me talk real quickly about these. So as we were saying, these are thoracic epineumomas, which are usually WHO grade 2, which is different than the myxopapillary type we discussed earlier, which is typically classified as WHO grade 1, though in general for spinal epineumomas, grading has not been substantially verified with significant studies and is often misleading, and assigning a grade isn't always correlating that well with survival or outcomes. It has a lot more to do with gross total resection. But if it is a typical thoracic epineumonoma, not this myxopapillary type, but a typical WHO grade 2 epineumonoma, you have a 50% recurrence within 4 to 5 years. And the gross total resection should always be attempted. If you have some studies say more than 15%, some say 10, they recommend radiation therapy. Otherwise, it's not recommended because it's such a slow growing tumor typically. And radiation, of course, has its side effects in the spinal cord. So Victor, here we go. We have a 46-year-old male with a history of elevated liver enzymes, hypertension. He presents with 6 months of intermittent left back pain, radiating down the anterolateral thigh to the top of the knee. Stops at the knee. And of note, it is worse with coughing and Valsalva. He was actually referred to us by the Palm Beach VA. He's a veteran. On exam, he had 5 out of 5 strength, but decreased sensation over the anterolateral thigh, proximal to the knee. Patellar reflex was 0, but otherwise reflexes were 2+ throughout. So what are we looking at here in terms of imaging studies? What do you see?
See a well circumscribed lesion at L2, looks intradural, extramedullary.
Yeah.
Some contact with the cord.
And it's enhancing, right?
Yep, homogeneously enhancing.
Yeah, very nodular, looking around. Looks probably benign in terms of features. It's not invading things around necessarily. You got the level right. What's it right next to? It's a very similar differential to our previous lesion in a similar area. Different pathology, of course, but what part of the spinal cord is it next to?
Near the conus.
Exactly. But then you can kind of see there's nerve roots going around it as well on that T2. So here's a better cut that kind of gives you a view here. It's hard to say definitively, but it's probably past the conus at this point because you can see all these nerve rootlets. And then here's the space occupying contrast enhancing T1 image. So differential.
Yep. So for something like this, intradural extramedullary, this has an appearance possibly of a meningioma. Need to rule out could also be a node-shaped tumor as well, although there's no expansion into the foramen, Chordomas, Neurofibroma, and metastases as well could be an option.
Perfect. Yeah, and the one we talked about before, honestly, this looks, the only thing different than a myxopapillary on the images is that it has a little bit more dense solid enhancement, but it's they can be deceivingly similar on T2 and T1 imaging. And then you hit it for the rest, schwannoma, neurofibroma, and possibly less likely meningioma. So Dr. Saad, I'll hand it over to you.
Okay, thank you. Okay, so this is the tumor at low magnification. There are 2 things that you can appreciate at this power. First of all, it shows hyper and hypocellular areas. And also there is what appear to be myxoid degeneration. I'll show you higher magnification in a second. And here, this is the only focus in the tumor that shows vaguely Verroquet bodies. So Verroquet bodies basically are palisaded cells around acellular area. The processes in the acellular area are thought to represent cytoplasmic processes of the palisaded nuclei at the periphery. So, and the tumor appears to be very well encapsulated. This is a fibrous capsule, and the tumor is completely contained within it. This is higher magnification, the hypercellular areas and the hypocellular areas. Obviously, the hypocellular areas are remarkably myxoid. Further magnification to show you the absence of tibia, pleomorphism, necrosis, or any other high-grade features. The tumor is diffusely positive for SOX10. So SOX10 is a transcription factor of all tissue that are derived from the neural crest. It doesn't tell us it's a schwannoma or neurofibroma, but it tells us it is of neural origin. S100 tells us it is of neural origin as well, and it is positive. Neurofilament is very helpful to distinguish between schwannoma and neurofibroma. So this is the peripheral, small fragment of the peripheral nerve, and you can see the axons. Actually, I have higher power. So this is higher power. You can see the neurofilament is positive in the axons. The axons are cut in cross-section here. And the tumor is negative, of course, because schwannoma is a tumor of the nerve sheath as opposed to neurofibroma. If this was a neurofibroma, you would expect to see some neurofilament positivity within the tumor as opposed to schwannoma. So we use neurofilament a lot in equivocal cases, just like in this one. So this is a schwannoma, WHO grade 1, no atypical features.
Thank you, Dr. Assad. That's great review for us, for the boards. Other, like you said, Verroquet bodies are one thing, and those stains are another thing to know. In terms of their presentation, they're usually WHO grade 1, slow-growing benign tumors. 75% actually arise from the sensory dorsal rootlets, so you often have early symptoms of radicular pain or radicular type symptoms, and they actually do say there's an association with coughing and Valsalva because of mass effect with CSF flow around the region of the tumor. It rarely recurs with complete resection, and if the patient is presenting with neurodeficits, that is a very late symptom. Most are solitary. If they are multiple, can be associated with NF2 and less commonly NF1. And like Dr. Saad alluded to, you need to make sure it's not a neurofibroma, and you can do that with the neurofilament stains and other things. It's almost entirely intradural, but there are some, about a third, that are completely extradural. And then there's some combined intra and extradural tumors that have been classified. But ultimately, it looks like a typical dumbbell shape intracranially and in the spine. It usually goes out the foramen. You can see on an X-ray widening of the foramen. If you get that boards question, it's just a very classic example of slow-growing tumor because it's able to impact the bone in such a way that is not breaking down the bone, just remodeling it. And then another big word for your boards to know is the Antony A and Antony B areas. So the Antony A is, as we were seeing on those slides, is the areas with compact interwoven bundles of Schwann cells. Those are the areas with compact cells that he was showing. And then the Antony B are those areas where there's loose matrix that's eosinophilic, or sorry, not eosinophilic, it's very purple on those stains, and there's a lack of cells. It's a loose matrix. That's the Antony B. Important to remember which is which. And that is all I have for that case. Good job, Victor. Thank you. And how about Turkey? Are you available? Hopefully you are. We'll start. It's a 38-year-old male with 1 month history of generalized malaise, fever, throat pain, difficulty swallowing, progressive neck pain, and then presented with 2 days of bilateral hand numbness and paresthesias. Actually presented to the ER at the beginning of these symptoms with the trouble swallowing. No imaging was obtained, which would be standard because he wasn't having any deficits at that time. But his difficulty swallowing and anterior neck pain became more like axial neck pain. And then he developed neurologic issues, and that's why he came back to the ER a month later. So Turkey, hopefully you're with me. This is his physical exam. Full strength throughout. He does have decreased sensation in bilateral hands and all 5 fingers. He has positive bilateral Hoffman's. Upper extremity reflexes are 2+, but the lower extremities are 3+ bilaterally symmetrically. He has upgoing Babinski's, which are positive, of course. No clonus and no bowel bladder involvement. So, Turkey, what do you see here?
Yeah, so it seems that this patient has C4 almost, destroyed vertebral body. Could be osteomyelitis, and he has some retropharyngeal collection. So this could be, the cause of his osteomyelitis with compression fracture or pathologic compression fracture of his C4. And there's, severe compression of the cord from that segment, which is, the cause of his neurologic symptoms.
Exactly, yeah. Infection is definitely high on the list here too. I'll show you, there's his T2. As you mentioned earlier, there's a lot of cord compression. And we have another image here showing the degree of enhancement. So other than infection, what are some other possible differentials?
Some of the primary bone tumor would cause, fever as a presenting sign, with also, axial neck pain and sometimes neurologic symptoms if it causes, compression fracture and also compression of the cord. I would say osteoblastoma. That's one of the differential.
Okay, I would add a few more to that. Bone metastases are common. He's young, he has no history of cancer, but there's other things like lymphomas, plasmacytoma, local spread of like a head and neck malignancy, multiple myeloma, meaning there's more going on than we see on just the scan. And there's actually a rare, but for boards, unifocal Langerhans cell histiocytosis, and that is especially presenting with cervical vertebraplana, which is what that essentially is at C4 with the vertebra collapsed. And infection, as you said, of course, should be on your differential. So Dr. Saad.
Okay. Okay. So this is the tumor. The tumor is solid, and there is no particular growth pattern. When we have a tumor like this, we rely a lot on these cytological features, and cytological features are very helpful in this particular case. So these are plasmacytoid cells. Plasmacytoid, we use the term, this term when the tumor cells appear to be plasma cells, but we haven't confirmed that by immunohistochemistry. So what is a plasmacytoid cell? A plasmacytoid cell is a cell where the nucleus is pushed to the periphery, but more importantly, there is a cytoplasmic clearing. We call it cytoplasmic huff, if this rings a bell, HUFF. And it is thought that the clearing or the cytoplasmic huff represents immunoglobulin that being stacked in the cytoplasm in preparation for its release into the circulation. So sheets of plasmacytoid cells, it would be wise to confirm that these are plasma cells, and they are indeed CD138, which is an immunostain for plasma cells, Now that we confirm that these are plasma cells, we need to confirm a clonality, and we do kappa and lambda. And this is in situ hybridization for kappa, and it's diffusely positive. So this is a plasmacytoma kappa restricted. To make the diagnosis of multiple myeloma, you need obviously staging such as urine electrophoresis and bone marrow biopsy. But as it stands, I cannot go further than plasmacytoma.
That's perfect. Thank you, sir, because that is what I'm going to focus on. That's awesome. Thank you for that description. So what is a plasmacytoma and why can't we say multiple myeloma without more information? So a plasmacytoma is a neoplasm of clonal plasma cells, so plasmacytoid looking cells. And it is a similar or maybe even a precursor to multiple myeloma, but it has to meet the following criteria. So there cannot be any other bone lesions on a complete skeletal survey. The bone marrow aspirate, which the patient had, has to show no evidence of myeloma. So he had a completely normal bone marrow aspirate, and his serum and urine electrophoresis were also normal and did not show that M spike of protein, the protein electrophoresis, which is a sign that patients have when they have multiple myeloma, of course. So how do you distinguish these two things? It's really important to know what's a plasmacytoma and why do we call it a plasmacytoma instead of why don't you just call it multiple myeloma? And it's because it is an isolated lesion, and there's no evidence of the full systemic multiple myeloma. However, over half of the patients with the solitary plasmacytoma will go on to develop multiple myeloma within 5 years and 70 to 80% by 10 years. So it's probably almost the first lesion or precursor lesion, if you will, but not all patients go on to develop multiple myeloma. So there's something we don't fully understand here. The treatment is initially radiation, but if they are unstable, as this patient obviously was, surgery is the appropriate treatment and resection of the tumor. This patient was treated actually by Dr. Benjamin and had a fantastic outcome. We saw him in clinic and follow-up. He's doing great. And he, because it's a plasmacytoma, does not require chemotherapy. And he will be getting radiation if his serial imaging per the oncologist and radiation oncologist show any recurrence. So he had a corpectomy anteriorly for treatment of this. And that is the end of my show.
Okay, thank you, everyone. Bye-bye.
Thank you, Dr. Slide.
Bye-bye.
Damien, are you ready?
Yes.
You would like to share your screen, please? Do you have any videos?
No videos.
Okay. Perfect. You're ready to go.
All right. Okay. All right. So good morning, everyone. Thank you for tuning into my Grand Rounds talk this morning and the last of the 2021 year. I'll be discussing current and future trends in spinal oncology. And thanks to Kat for prefacing some of this talk with her neuropathology slides today. So I'll first be reviewing the basics, including anatomy, imaging characteristics, differential diagnoses as it relates to some of the primary spinal cord lesions and metastatic lesions as well. And then I'll discuss some of the interesting historical elements as it relates to treatment paradigms and how management of different spinal lesions has evolved over the last century or so. And then the focus of my talk, of course, will be examining key management principles as well as the current evidence and guidelines for each of the tumors that we most commonly treat, and finally highlight some interesting and impactful future directions that the field may head in over the next couple decades. But first, I want to discuss sort of how this all started, how this talk came about. The impetus, for this particular Grand Rounds talk, stems from my interest in spinal oncology, and wanted to familiarize myself more with the topic, as a junior resident, but also stems back to as a rising sophomore in undergrad during a summer shadowing program. I had the opportunity to observe my very first neurosurgical case in an intradural cervical tumor resection, much like the one seen here. And this was actually with Dr. Mark Lee at Lehigh Valley Health Network at the time. And he unfortunately passed away earlier this year after battling ALS. But I'll forever be grateful for that opportunity he gave me. And that really led to the opportunity today to speak with all of you. So with that being said, I'll get into the neuroanatomy and imaging review, as we briefly just touched on with neuropathology, but the three main components: extradural, metastatic lesions, primary bone tumors. Then we move into the intradural component, meningiomas, schwannomas, neurofibromas are the more common ones. And then intradural, intramedullary lesions tend to be astrocytomas and ependymomas, among a small handful of other various pathologies that are much more rare. So to start, extradural tumors, metastatic lesions are typically the most common. The focus of this talk. Most commonly lung, breast, prostate cancers metastasize to the spine. Multiple myeloma, blood disorders are also very common, such as plasmacytoma. That can cause large compressive lesions and push us towards surgery if needed. One of the main considerations and differentiating some of these metastatic lesions is whether they're osteoblastic versus osteolytic. In men, prostate, and in women, breast tend to be more the osteoblastic tumors, and the rest generally are osteolytic. And then we have the primary bone tumors that we also see a bit less commonly, chordoma obviously being the most malignant, very poor prognosis, and then benign lesions such as osteoid osteoma, which are less than 1 centimeter. If they're greater than 1 centimeter, they become osteoblastomas. These tend to have a high cure rate when they're completely excised. An important board's point is that it's pain relieved with aspirin use. And then another interesting bone tumor we've seen a handful of over the last year or so are aneurysmal bone cysts, and that's seen here. These are expansile osteolytic lesions, highly vascular, often have these sort of cystic appearing component and these air fluid levels that can be seen and are somewhat pathognomonic. But these tend to have, although are locally aggressive, and tend to have a very high recurrence rates, if not completely resected. Moving intradurally now, we have the intradural extramedullary tumors. These tend to be slow growing. The symptoms progress over time. Meningiomas, most commonly, they're primarily intradural, but they can extend extradurally, especially as they grow to be a bit larger. Seen here as an example, classic appearance, homogeneously contrast enhancing, small little dural tail seen there. And then as you can see, it's intradural, but extramedullary, displacing the spinal cord to the left up in the upper cervical spine here. Next, we have neurofibromas, most commonly sporadic and solitary, but they're also associated with NF1 and NF2, which tends to be the more common presentation. And then finally, schwannomas primarily arise from dorsal sensory rootlets, causing radicular symptoms, and they often have non-functional nerve roots associated with them within the tumor. These can be identified intraoperatively with neurostimulation to safely resect the lesion. And these are characteristically often have a cystic type appearance or a dumbbell shape that can be seen on an axial cut that help differentiate these from meningiomas sometimes within the spine. And then, as Kat just briefly mentioned too, they have the Antony A and B cells, board's favorite. The Antony A are the compact bundles of long Schwann cells, and Antony B cells are sparsely distributed in an eosinophilic matrix. And then furthermore, just briefly, there are numerous classification systems that I'll touch on towards the end of the talk that are used to guide surgical resection approaches specific to schwannomas. And then, of course, metastases are less common, although can be seen. And then finally, we have the intradural intramedullary compartment, primarily made up of astrocytomas and ependymomas. These types of tumors nearly always enhance, although some astrocytomas do not. They initially present with pain, then progress to sensory and motor deficits over time. And astrocytomas, typically low grade, can be difficult to see on the T1 image just seen here, but with contrast, you can see this sort of diffuse infiltrative process within the spinal cord, and it very clearly is intramedullary. This is in contrast to ependymomas, which tend to be cystic, are more encapsulated, typically making surgical resection a bit easier, but obviously can be very difficult to resect, particularly if they're quite large. And when they occur in the conus and the phylum lower down in the spinal cord, they're termed myxopapillary ependymomas, which are WHO grade 1 lesions. These tend to be solitary, although it is important to remember with ependymomas, they require complete neuraxis imaging to rule out CSF seeding. And there are various different subtypes, including papillary, cellular, epithelial, mixed histologic types of ependymomas. And then there are some other ones that are less common. Hemangioblastoma, well demarcated, highly vascular. About a third, though, are associated with von Hippel-Lindau, so it's important to be aware of that if you come across a patient with hemangioblastoma. And then GBM, lipomas, these tend to be associated with spinal dysraphisms as well. So now moving on to some of the historical context and background of the last century or so. The first recorded laminectomy for spinal lesion was done in 1887 by Sir Victor Horsley. It was a case report of a 40-year-old man presenting with severe lower back pain, ultimately progressed to paraplegia, loss of sensation, and urinary retention over several months. It was reported that it was a fibromyxoma that was resected. Patient, however, subsequently returned to walking and working postoperatively, so it appeared that the surgery was successful. Christian Fenger then in 1890 attempted to remove an intramedullary lesion, although unsuccessfully so. And Anton von Eiselsberg was credited with first accomplishing this feat in 1907. Then a few years later, Ellsberg and Beer described a two-stage operation for resection of intramedullary lesions in 1911. It was an interesting approach. They made a posterior midline myelotomy overlying the tumor. Then they left the dura open and closed the wound itself, and allowed about a week or so for the tumor to partially extrude itself from the spinal cord. And then they went back in after a week and reopened the wound and resected the extruded tumor. There are also some various imaging modalities that came about over the last century that led to improvements in surgical resection. In 1921, Pneuma Myelography was developed and used for diagnosis of spinal cord tumors. This was similar to Walter Dandy's work with pneumoencephalograms and for identifying intracranial tumors. And then in 1922, Sicard and one of his students accidentally discovered the use of lipiodol for visualization of the intrathecal compartment. They had been studying and injecting it into the epidural space, but unsurprisingly, one of his students intentionally injected it into the thecal sac during a particular experiment, and they were able to see fluorescent dye within the thecal sac, and it was used well into the 30s, despite it causing concerns of arachnoiditis. However, in the 80s, iohexol, iopamidol, which are non-ionic water soluble, became the standard that are still used today for myelography. And then, of course, CT MRI subsequently became the gold standard, and those were introduced later on in the 1990s. But interestingly, the initial MRIs we used were 0.15 Tesla magnets, and it took up to 40 minutes just to get a T2 weighted image of the spine for these images, which actually is, sounds like about on par with Jackson's standards today. But some of the technology that was advanced during the time was 1940s. James Greenwood began developing micro instruments, including suction bipolar forceps for use around the spinal cord. And this was around the same time that Yassergill was utilizing the operating microscope for neurosurgical procedures. So these sort of went hand in hand. And that was aided by Leonard Mallis, who began commercializing the bipolar cautery in 1955 and began using it during some of his spinal cord dissections. Interestingly, myeloscopy was briefly utilized, most notably by Lawrence Poole. He published a case series of 400 plus patients that he described visualization of structures within the spinal canal and the myeloscope that he used, as seen here on the right. It's an enormous device. It was inserted between the spinous processes, similar to a lumbar puncture needle, and he was able to observe dorsal nerve roots of the cauda equina, blood vessels, as well as reportedly different pathologies such as arachnoiditis, neoplasms, herniated discs. Unsurprisingly, though, interest was tempered because of the morbidity associated with sticking such a large tube into the spinal canal. And so it really was phased out until surgeons like Parvis Camden pioneered safer ways to utilize endoscopy within spine surgery. And then finally, some of the historical management principles. Primarily radiotherapy was the treatment paradigm well into the 1980s. This paper that was published in 1980 in JNS for the treatment of spinal epidural metastases was a randomized prospective trial comparing laminectomy followed by radiotherapy to just radiotherapy alone in the treatment of epidural spinal disease. And they found no significant difference between the effectiveness of the two treatment methods related to pain relief, improved ambulation, and/or sphincter function. So essentially what they found, patients with an incomplete injury fared well regardless of treatment, and those with a complete injury, as expected, fared poorly. So the radiotherapy treatments that were used at the time and are still used today, conventional external beam radiotherapy is the most common method. Treats a wide target field. All the tissues receive a prescribed dose of radiation, either 8 gray in 1 fraction, 20 gray in 5, or 30 in 10 are some of the common fractionated treatment patterns. But they are impacted by radiosensitivity differences among the various histology types. And that's something that we'll get into when we discuss the NOMS criteria shortly. However, stereotactic radiosurgery was introduced in 1951 by Lars Lexell. We all know about the Lexell frame. And that then was subsequently applied to the spine for the first time in the 1990s. In 1997, the CyberKnife was developed, became a frameless robotic radiosurgery platform, and it helped advance stereotactic radiosurgery systems for spine tumors. So now moving on to some of the key management principles and some of the landmark papers that are commonly cited, things need to know for the boards as well as just in general treatment paradigms. Starting off with, of course, Patchell et al., published in Lancet in 2005, and it discusses the randomized trial of direct decompressive surgical resection in the treatment of spinal cord compression from metastatic disease. So it was a randomized multi-institutional trial for patients with spinal cord compression. They were randomized either to surgery plus radiotherapy or radiotherapy alone. Both groups received 10 3-gray fractions of radiotherapy. The primary endpoint that they used was the ability to walk. It was relatively straightforward with additional secondary endpoints, including things like urinary continence, muscle strength, functional status overall, and survival time, importantly. And in short, what they found was that direct decompressive surgery plus postoperative adjuvant radiotherapy is superior to treatment with radiotherapy alone, which is the opposite of what the paper in 1980 from JNS had described. And so this really became a landmark paper and something that we still base a lot of treatment decisions on today. And so delving into a little bit of the data, significantly more patients in the surgery group, 84% to be exact, compared to the radiotherapy group, just 57% were able to walk after treatment. And those patients, as seen in the Kaplan-Meier curve on the left, demonstrated or were able to retain the ability to walk for a significantly longer period of time after treatment. From 122-day median versus a 13-day median in the radiation alone group. And then 32 patients in the study entered the study with the inability to walk at all. And significantly more patients again in the surgery group subsequently regained that ability to walk after treatment compared to the radiation group. And that's shown in the Kaplan-Meier curve on the right. Furthermore, seen in the bottom row here, overall survival time in the surgery group was significantly increased. The authors attributed the better survival time in the surgical group to the fact that more patients were ambulatory and regained the ability to stay ambulatory for longer, making them less susceptible to infections, blood clots, and other problems that often resulted in the death of the less functional patients. And their theory that they posited was that the direct compression of the tumor results in edema, venous congestion, demyelination of the spinal cord, but that this process, if it's for a short duration, is ultimately reversible. The quickest way to do that would be with surgical decompression, and they found that if patients underwent radiosurgery, that effect was it took several days to develop. And so that's what they thought was part of the reason that these patients were not recovering the ability to walk as quickly or as often. And so now moving on, the other landmark paper, the NOMS framework, is an approach to the treatment of spinal metastatic tumors, published in 2013 from Sloan Kettering, describes a useful framework for surgical decision-making for spinal metastases. Has become one of the standards today for evaluating the patient with spinal metastases and whether or not they need to go to the operating room or get surgery. The first criterion is neurologic. So this consists of the degree of epidural spinal cord compression, myelopathy, and or functional radiculopathy that a patient may present with. And the spinal oncology group developed this grading system seen here on the right for epidural spinal cord compression. Grades 0 and 1, including A, B, and C, are lower grades and tend to be, in the absence of any mechanical instability, considered as radiation for the initial treatment. There's no spinal cord compression in any of these groups, although grade 1C is sort of equivocal, and maybe some newer treatments like high-dose hypofractionated radiation could allow administration of radiosurgery while avoiding some of the spinal cord toxicities, given it's in relatively close proximity to the spinal cord. And then, of course, the higher grade lesions 2 and 3 demonstrate spinal cord compression with either CSF or complete effacement of the CSF spaces around. These, generally are treated with surgery unless the tumor happens to be incredibly radiosensitive. The next category, oncologic. And in short, this is how responsive the tumor is to the currently available treatments. Radiation tends to be the focus, external beam radiotherapy, stereotactic radiosurgery. That's the least invasive method for tumor control. And so a lot of the data for this type of, for this criteria focuses on the relative radiosensitivity to tumors, things like myeloma, lymphoma, very radiosensitive, versus melanoma, renal cell carcinoma, which tend to be radioresistant. The next, mechanical instability. So it's important to note that this is independent of the epidural spinal cord compression grade or tumor radiosensitivity. And so it's a separate consideration defined for any pathologic fractures. That treatment options include bracing, percutaneous cement, pedicle screw augmentation, or open surgery, all of which we'll discuss in a bit as well. But it serves as an indication for surgery, again, regardless of the neurologic or oncologic assessment. And they define spinal instability as the loss of spinal integrity as a result of neoplastic process that's associated with either movement-related pain, symptomatic or progressive deformity, and or neural compromise under physiologic loads. However, it is important to differentiate pain from mechanical instability, for example, subaxial cervical instability from a cervical tumor that may manifest with pain with flexion and extension that corresponds to this dynamic instability that can be seen on imaging with tumor extension into the joint or something like that, from the biologic pain associated with the cancer itself that tends to be present at night in the evenings and more readily responds to things like steroids and or radiation treatment. So one way to categorize the instability in a patient is this SIN score, spinal instability neoplastic score, also taken from the NOMS framework. And they use various different categories of scoring, location, pain, types of lesions, whether there's any vertebral body collapse or posterior element involvement to determine whether the lesion is stable or unstable. Or intermediate, in which case, further assessment is really needed to determine the role for surgery. And then the final component in the NOMS criteria is systemic treatment, and this ultimately determines what a patient can tolerate physiologically, dependent on the extent of tumor dissemination, any medical comorbidities that these patients may have, as well as the tumor histology itself. And ultimately, individualized discussion with the patient is key to determine exactly what how aggressive they want to be in terms of treating their cancer. And so here is the flow chart from the NOMS criteria that nicely organizes everything: neurologic, oncologic, mechanical, and systemic. Of course, if a patient is unable to tolerate surgery, we're not going to put them through surgery. They'll go to radiation. Or conversely, if the patient has a unstable fracture independent of any of these other factors, they automatically should get stabilization. And then another framework and mnemonic to think about is the LMNOP system developed in Canada. It was published, I believe, in 2011. And it included many of the same principles as the NOMS criteria. The authors argued it was easier to remember given it was part of the alphabet. But they also included different levels such as solitary or multi-level disease, as well as if there was any prior therapy that patients had received, whether they had failed multiple systemic treatments or they'd been previously radiated at the symptomatic levels. And so with that, we'll sort of delve into some of the current evidence and practice standards today, some of the common treatment methods for these various tumors, initially starting with, staying on the topic of spinal metastases. Stereotactic radiosurgery remains a very common treatment method. It delivers ablative radiation doses to the target with sub-millimeter accuracy. And so this minimizes the radiation doses to off-target normal tissues. And results have indicated excellent local control up to 70 to 100% in some studies for both intact vertebrae as well as patients that have had prior surgery. And this appears somewhat independent of the innate tumor radioresistance to these lesions. And so the figure seen here is a figure taken from the consensus contouring guidelines that the International Spine Radiosurgery Consortium has this classification scheme. And essentially the principle is whatever segment there's gross tumor involvement in, for example, if it's within just the spinous process, then as a general rule, the target volume should cover both of the immediately adjacent segments, such as 3 and 5 in this case. The one exception is that if it's tumor just involved in zone 1 here in the vertebral body, that tends to be just targeted on its own. Then, of course, there's surgical management for these lesions. Separation surgery tends to be the mainstay today. It creates space between the tumor and the spinal cord, often via transpedicular approach to obtain circumferential dural decompression, and is a combination of generally open surgical decompression with or without fusion, the common 2 above, 2 below rule for instrumenting these types of injuries. And this table here I thought was just an interesting or helpful framework and way to sort of approach thinking about from a junior resident's perspective. There was a patient with a cervical tumor, how would you approach the surgery? So can you come from the front? Can you come from the back? Do you need to fully do just a laminectomy, or do you need to widen the decompression and take out the facets, in which case it would push you more towards requiring instrumentation and or fusion. And so touching a little bit further on separation surgery, this paper, again, out of Sloan Kettering, described their experiences using separation surgery followed by high-dose fractionated stereotactic radiosurgery. It was published in 2013 and ultimately what they showed was that postoperative radiosurgery after separation surgery is a safe and effective strategy for establishing dural local tumor control. And importantly, interestingly, they found it was regardless of the tumor radiosensitivity. They showed that patients with high dose hypofractionated radiation, meaning less fractions, but a higher dose at one time, demonstrated a 1-year local progression rate of less than 5%. That was far superior to the results of the low dose hypofractionated radiosurgery, and that was aided by being able to separate the spinal cord away from the tumor and provide just a few extra millimeters of space. There are also various staging and classification systems, the WBB or the Weinstein-Boriani-Baggini classification system. This can be used to guide surgical decision-making based on the different zones of a lesion. Corpectomies could be considered for lesions that are primarily within the anterior part of the vertebral body versus zones 3 through 10. May be more amenable to a posterior-only approach versus a lateral approach for maybe a lesion that's sort of involving the either lateral aspect of the vertebral body. And then there are different technologies that have been developed over the years, different treatment methodologies, including instrumentation, augmentation, such as cement augmentation via fenestrated pedicle screws. This has been shown to enhance the durability of instrumentation constructs. This was a retrospective review, 53 patients, a total of 216 screws, and they found just 1 screw fracture in 6 months, and it was asymptomatic. The patient didn't require any surgical intervention to treat it. But importantly, there were 8 patients that were found to have asymptomatic cement extravasation into the venous system. However, some of which were symptomatic, including PE, DVT, and one patient actually died from widespread cement emboli. So there is, although a rare, but albeit real risk when using cement augmentation. And so it is something to consider and discuss with patients prior to the OR. Furthermore, there's percutaneous cement augmentation outside of any instrumentation via vertebroplasty, kyphoplasty, or the spine jack seen here. The goal in these cases is to just stabilize a vertebral body fracture and reduce the associated mechanical pain caused by it. But it is contraindicated in fractured or absent posterior walls and to avoid retropulsion of cements within the canal. And then furthermore, instrumentation materials have adapted as well. More recently, carbon fiber reinforced PEEK screws and implantation devices have been used for fixation. The idea is that they reduce artifact formation on imaging and they cause less scattering of radiotherapy. It's reportedly been shown that they lower the degree of dose degradation and may allow for improved image quality on CT images to better calculated dose accuracy. And so this paper was a trial that looked at carbon fiber reinforced PEEK cages versus titanium. And two of the examples are seen here. This is an ACDF plate that's carbon fiber reinforced, as well as some thoracic or lumbar instrumentation here. But interestingly, they didn't find any significant differences in any of their outcomes, but particularly as it related to postoperative hardware-related complications. There were no instances of hardware complications versus just 2 in the titanium group. Mean follow-up was at 6 months, so maybe long-term there might have been a more significant difference, but it doesn't appear at this stage that there's one clear indication necessarily one way or the other to use carbon fiber or not.
Hey, this is great, Damien. I was just going to give a plug for the co-sponsored Ortho Neuro grand rounds by Larry Rhines in mid-January, and Isotech, who does the carbon fiber screws, is going to be doing a lab. I think we're still figuring out exactly the date, but sometime during the 26th. Yeah, so there'll be an opportunity to use those screws in a cadaver lab to see how you like them.
Perfect. Yeah, I'll be looking forward to that. So I think there's new studies coming out. There's not a lot of evidence, and so I think that doing more labs and things like that will definitely potentially make it a very valuable tool going forward. And then briefly, just touching on the last component, I'm not going to get into it. There's a ton of information, data, different chemotherapy, immunotherapies that are coming out for the various different types of spinal metastases. But now switching gears a little bit, that was sort of all metastatic disease. There's a lot of data out on that, but focusing on some of the current management principles and keys for some of the primary tumors. This is just an example of the Asazuma dumbbell classification that's only used for cervical schwannomas, but can help guide some surgical decision-making in terms of how to approach some of these slightly more complex schwannoma tumors. Seeing here type 1A or type 1, 2A, 2 and 3A generally are more amenable to a posterior only approach versus tumors that extend much more laterally beyond the vertebral artery, may require a combined anterior posterior approach. A little bit more simplified, the Sun and Pamir classification for schwannomas takes into account not only size, divided into 3 different groups, A, B, and C, but also type as it relates to extension within or outside of the spinal canal. So type 1 is solely within the intradural component within the spinal canal. Type 2 is intradural with some extradural extension into the foramen, but it's still localized within the spinal canal. And then type 3 is a combination of within and outside of the spinal canal. And type 4 solely exists outside of the spinal canal along the nerve root itself. Furthermore, there's management of the intramedullary lesions, including ependymomas. Gross total resection remains the gold standard. There's a clear survival benefit demonstrated as expected with removing the entire tumor. And as I mentioned previously, they're tend to be well encapsulated, making surgical resection a bit easier as compared to astrocytomas. But radiotherapy in these cases is reserved generally for high-grade or subtotally resected lesions, although there's no real general consensus as to whether there's a clear benefit for adjuvant radiotherapy. And traditional chemotherapy also tends to be, ineffective, although there are newer PDGF, mTOR inhibitor targets that have shown some promise in limited trials. But again, there's just a paucity of cases that are relatively rare. Tumors with even rarer high-grade lesions. So it's not as easy to study in a overall fashion. Next is astrocytomas. Maximal safe resection tends to be the gold standard, balancing, however, the extent of resection with causing iatrogenic harm, as these tumors tend to be more infiltrative lesions. And so it's a bit harder to get a gross total resection when the tumor is involved within the intramedullary compartment itself, or within the spinal cord itself. And again, adjuvant radiotherapy, temozolomide, which sometimes is used in astrocytomas intracranially, it tends to be less effective for spinal lesions. But there are newer inhibitors of BRAF and MEK that have demonstrated a durable anti-tumor activity in one of the recent trials that's come about. And then just to touch on briefly, chordomas is sort of a hot topic. There's a lot of research being poured into the microbiology of these types of tumors in terms of trying to find a cure or at least better treatment modalities for these tumors. And again, the extent of tumor resection, though, still remains the gold standard. Wide en bloc resection, trying to get the entire tumor out, often requires a multidisciplinary approach, particularly if it's in the sacrum. These are massive surgeries. But there are not other great adjuvant treatment options. Proton beam radiotherapy is the preferred modality, particularly if it's done immediately post-operatively after the initial diagnosis, prior to it recurring. But there are some interesting molecular targets. Tyrosine kinase inhibitors have shown some promise, as well as immune checkpoint inhibitors. And then brachyury silencing, which I had actually not heard of before, is currently being evaluated in clinical trials. Brachyury is been shown to promote epithelial to mesenchymal transition, which is involved in tumor progression and metastasis as the cancer cells transform into an epithelial phenotype, or from an epithelial phenotype into a more motile mesenchymal one, and are able to metastasize and spread. And so they're developing different vaccine platforms to target induce immunization against brachyury, and maybe this may lead to a breakthrough down the road for chordoma management. And so finally, I'm going to touch on some of the future trends and where the field seems to be heading. Briefly, the percutaneous ablation techniques can be used: cryoablation, radiofrequency ablation, microwave ablation, and then slit as well, which has become much more popular. This is spinal laser interstitial thermal therapy. Tends to be aided by the use of an intraoperative MRI. This paper, they derived it from the concept of separation surgery that was used to ablate epidural metastatic disease. And this is more of a palliative treatment in patients that are likely unable to undergo a large surgery. They use a 1.3 millimeter laser catheter percutaneously placed into the epidural space, into the tumor itself. And then obviously use a laser to heat it. And they use an intraoperative MRI to monitor real-time thermography to balance the heat map within the tumor. And it's been shown in combination with stereotactic radiosurgery to reduce the epidural tumor volume, decrease pain, improve overall health-related quality of life. Such metrics like VAS and EQ5D have been improved. And importantly, one of the main advantages is that it allows patients to return to their systemic treatment, either radiation, chemotherapy, very quickly after treatment, just 5 days on average. Much longer than the usually typical couple weeks, just 2 to 4 weeks we wait after a surgical intervention. However, it is a palliative treatment, and so it's maximizing local control with the radiosurgery. Is ultimately the goal is to prevent neurologic decline, facilitate a faster recovery, and again minimize interference with other oncologic therapies. It is limited though by the resolution given the patient's physiologic movement, some studies have shown breath holding during the ablation allows for a little bit more precise monitoring, but it's still pretty dependent on the surgeon to delineate the different anatomic structures as it relates to the ablation zone during the actual treatment. And then there are more surgical techniques that have been developed, including minimally invasive surgery. It's become obviously very popular within spine surgery as a whole, and this is translated to the spinal oncology realm. Dr. Uribe has previously published on a case series of thoracic spinal cord tumor removals using a single position, mini open lateral approach, and stabilize the patient without having to flip intraoperatively or reposition. And this has the added benefit of avoiding some of the cardiopulmonary complications that can be associated with prolonged prone positioning anesthesia. And again, this has been aided by advancements in recent advancements in neuromonitoring that allows for safer navigation around the lumbar plexus, for example. And so this study, Dr. Uribe, they demonstrated 21 consecutive patients with a mean improvement in VAS and ODI scores overall, and they found just one perioperative complication, which was a pneumonia in a patient, but there were no intraoperative complications, no pneumothoraces or pseudomeningoceles that they found, and just 2 patients were noted to have some residual tumor, which was asymptomatic, and they didn't require any additional treatment. Endoscopy has also come a long way from the myeloscopes that were used back in the mid-1900s. This case series discusses 18 patients with intradural extramedullary tumors using resected via an interlaminar approach, combining a microscope in most of the cases, 15, as well as a microscope with an endoscope. And they felt that the authors felt that this approach was advantageous because it caused even less bone destruction. They found no signs of any laminar bony defects, and they were able to completely remove all of the lesions, primarily of which were schwannomas in this series. And overall, it led to a quicker functional recovery for the patients, and most of the patients had significantly less pain with improvements in motor and sensory functions after surgery. There are also case reports of endoscopic surgery under local anesthesia. This was a 16-year-old female that had a prior T4 to 7 laminectomy infusion for a tumor resection, but it had come back, and the diagnosis on the biopsy was sort of inconclusive. And so they, in a very minimally invasive approach, partially resected and biopsied the lesion, and a completely endoscopic and a weight case. So that was an interesting concept. I'm sure that some people will continue to further develop as well. And then moving on, of course, robotics has become very popular. The Vinci Robot and a couple case reports have been used to describe excisions of some paraspinal lesions. Whether or not this is going to carry over and the technology will be used for intradural lesions remains to be seen. But I think at a minimum, the robots like the Mazor X, which are instrumentation guidance systems, definitely will allow for more accurate screw placement, particularly in some of these complex reconstruction cases for big spinal metastases and vertebrectomies, may make more accurate instrumentation feasible. And furthermore, it can limit exposure to limit the exposure size and reduce blood loss, particularly in cases like highly vascular tumors, renal cell carcinoma, and the like. And then finally, just to touch on some enhanced recovery after surgery. It's a topic dear to my heart. I spent a lot of time developing the program here, and something that I think is very valuable, not only in general for spine surgery and neurosurgery as a whole, but currently there's very limited applications and data regarding ERAS programs for spinal oncology. This paper is from 2018. It's the only one out there that the group at MD Anderson, who has been heavily involved in ERAS programs for the last several years, published on initially. But there have been really no follow-up since, and it doesn't appear in the literature that anybody else has really taken a step into looking at this. But I think these types of patients tend to be very complex, require very complex perioperative care, and so I think something like an ERAS program that guides patients every step of the way, optimizes them before surgery, utilizes intraoperative techniques to help reduce some pain postoperatively and get patients in and out of the hospital sooner with less complications. I think this would be a great application, especially at a large cancer center like we have here with Sylvester and to certainly work on and develop going forward. I think there's a lot of room for growth in the management of these types of patients. And so, in summary, we discussed that while spinal tumors are a rare pathology, they tend to be limited to several common tumor types that we discussed. Historical developments over the years and different techniques and technologies have really spurred the growth of a lot of the current treatment modalities that are still in use today. And we touched on several key studies like Patchell, the NOMS framework for management of spinal metastases. But there are also, primary tumors that tend to favor surgical resection. But obviously, the extent of resection must be balanced with the risk of causing iatrogenic neurologic harm to the patient. And now, current research, whether it be devices, management paradigms, novel therapies, are showing promise in improving survival for patients with all types of spinal lesions. With that, I thank you for tuning in and listening this morning. I'd be happy to take any questions.
Nice job, Damien. That was an awesome talk. Really enjoyed it.
All right. Well, I think with that, we conclude the grand rounds for 2021.